Hi, folks. I'm Dan Dworkis, and this is the Emergency Mind Podcast, a space where we bring together lessons from the emergency department and beyond about performing at our best when it matters the most and applying knowledge under pressure. The Emergency Mind Podcast is brought to you by the folks at Mission Critical Medicine, which is a division of the Mission Critical Team Institute. If you want to find out more about what we're doing, you can find us at missioncti.com. All right, we have two guests today, which is awesome. First off is Eric Benoit, who is an acute care surgeon at Lahey Hospital and Medical Center, which is a level 1 trauma center just north of Boston. He's also the medical director of the Surgical Intensive Care Unit and an assistant professor of surgery at Tufts School of Medicine. And then also is Andrew Petrosoniak. Andrew is an emergency physician and trauma team leader at St. Michael's Hospital in Toronto. He's also the medical director of simulation for Unity Health and an assistant professor at the University of Toronto. Now, aside from all that, he's also the president of Advanced Performance Healthcare Design, a simulation-based design firm. Aside from that, I will tell you that he's much taller in real life than he is on the Zoom screen, which we got to find out the other day. I guess it's a little longer than the other day at this point, right? When we met back at TAC Trauma. So Andrew, Eric, welcome to and welcome back to the podcast. Happy to have you guys.
Yeah, thanks, Dan, and great to be here with Eric.
Yeah, good stuff. So this conversation happened, or rather, let's put it this way. The reason we're having this particular conversation is off the back of a bunch of individual conversations we've had over the last little bit, circling largely around the ideas of uncertainty, risk, and learning how to perform in the wide variety of circumstances that we find ourselves either in the ER, the ICU, or in the operating room. And we've been kicking around some ideas here. Our hope for this conversation is not that we solve all of uncertainty, but that we walk away with it maybe a little better to handle some of the uncertainty that's baked into and inherent in the work that we do. What I think is interesting about this is that we have a variety of different opinions among folks here in terms of how we practice, where we practice, and the things we do outside of our actual direct clinical practice, all of which are aligned with each other, but different enough that I think there's some heterogeneity here that's worth sampling. I'm going to start with a bit of an abstract one, and then I think we're going to drill down from there. But gentlemen, how much uncertainty do you think that we can actually get rid of?
No, Andrew, if you're okay, let me take that to start. How much uncertainty can we get rid of? Particularly if we're dealing with a time-sensitive thing, if we're in the trauma bag or something like that, somebody who's sick. Not a lot, right? I think the problem is trying to resolve uncertainty takes information, and information takes time, and it takes cognitive effort. And trying to resolve the uncertainty is a challenge. Because I think if that's what you want to do, if you want to get to a space where you've gotten rid of all the uncertainty, you may know everything, but then you've got a dead patient.
Yeah, that's right. Like all arrhythmias resolve eventually. If you give it enough of a time frame, you run out of everything, goes to entropy, and the person's dead, and you have achieved certainty, but it's certainty of death.
Right. All bleeding stops.
Yeah.
I guess I think we're certainly striving towards gaining certainty through these decisions, through this process. In fact, just recently I was working with a trainee and patient came in hypotensive. So if we anchor it on a bit of a medical lens, probably zoom out on that. And they were fairly junior. So they were alongside me as we were managing this hypotensive patient, blunt trauma. And we didn't know exactly why they were hypotensive. These would be familiar situations to both of you. But we were reflecting afterwards, and really as we were talking after with the trainee, I said, what I'm trying to do is just buy myself 5 more minutes. And then if I buy myself 5 more minutes, and then I buy myself another 5 more minutes, and another 5 more minutes, now we have 15 minutes that we have this patient alive that if they were on the street, they wouldn't have been. And so what were we trying to do? Well, we didn't know what was going to happen. So you don't always need to achieve certainty. You just need to be able to do the things that will allow you a little bit more time to find out a little bit more information. So the point of it in the moment of that trauma resuscitation wasn't actually to figure out where they were bleeding. And I think that's sometimes the challenge. If we actually use some first principles thinking, sure, we want to know at the end of the day where this patient's bleeding, because Eric's going to take them to the operating room at some point. And he may not even know before he gets to the OR. It's a best guess. But really what is our overall guiding principle here? It's keep this patient alive. And so certainly if we can see a tourniquet that needs to be applied and there's obvious bleeding, great. But most of the time it's occult, it's cryptic from us, and we get some indicators. But what we were trying to do in this instance, and what I was trying to speak with the trainee about as we were debriefing, I just needed IV access and I needed to get patient blood. And then we were going to empirically decompress the chest in this particular instance. And that just buys us a little bit more time. So our main goal was not, let's figure out where they were bleeding. That wasn't actually the goal of the moment. The goal of the moment was, or the goal of the entire thing, the resuscitation, is keep this patient alive and get 5 minutes further down the line.
Yeah, perfect. So one of the reasons I wanted to start with this sort of like vague concept is I think that there's a lot of frame in a lot of the worlds that we work in that uncertainty is the enemy, right? And that the goal is to make uncertainty as close to zero as possible. And that when you do that, you'll suddenly know what to do and be able to do it. And there's just so many logical twists and turns in that sentence. But I think if you made folks outside of this world say it, they'd be like, yeah, uncertainty is bad. If I eliminate uncertainty, I'll know what to do, and then I can activate on it. But what Eric's saying is this concept of, sure, certainty is mostly better than uncertainty, but there's a cost for eliminating it, and we don't always want to pay that cost. And what Andrew's saying in some sense is the opposite of uncertainty is not always certainty. Sometimes it's just action, right? Sometimes it actually doesn't matter. You're just going to go do the thing anyway. And I think exploring that is really tricky and not obvious, I think, especially when you start in this world.
Yeah, I think at least in medicine, there's this idea as we all came up, you study enough, you put in the time, enough patience, you're going to learn it, and then you're going to be comfortable. And I think that's the more I do this, and I'm sure you guys have the same experience, the more you do it, the more you realize, yeah, that's not true, right? That how often do we say the patients don't read the textbook? Every situation is atypical in its own way. And you can't study your way out of a lot of this uncertainty. And Andrew, what you say with your example, it's perfect, right? And that's what I try to preach to, I guess I'm preaching to my trainees, is there is not always an answer, or there's not an answer within a timely fashion. And therefore, you need to take the steps, you need to act without knowing, you need to do things to move the ball down the field. To me, this has become an extension of the concept of damage control. In trauma surgery, we do this all the time, right? We can't fix everything. We just want to kind of stabilize the patient in the operating room, stop the bleeding, plug the holes, they go to the ICU to reset their physiology a little bit. But the goal of that is to buy time. That's to buy time for the patient to do some recovery. And what I've found in my practice is that's reaching into the way that I think about things in a trauma bay or other like critically ill patients. And like you say, Andrew, you got to buy 5 minutes, another 5 minutes, and then you have some maneuvering room. So to me, uncertainty isn't the enemy. That's the space where we live, right? That's where we work. And rather than try to work my way out of it, what I've come to is I want to get comfortable with it, steer into that skid and work in that space, because there's not going to be an answer. So fine, let's just do what we need to do to try to get us to a point where we can act and keep the patient alive. I had a professor who used to say you can do a lot with a live patient, but you got to keep them alive and then you can figure yourself out. And so it's all about buying yourself a little bit of time. You don't have to be right. You don't have to make the perfect decision. You got to make a decent enough decision to move the ball down the field a little bit.
I think just to build on that, Eric, I remember somebody telling me, you don't need to be, you just don't be wrong. So it's not so binary. It
Sure.
reminds me also, as Eric was talking, recently reflecting on the movie The Martian. And
Sure.
at the very end, Matt Damon, the character who was on Mars for a period of time, is speaking to a class, and they were asking him about how he basically survived and got through that. And he starts describing it's fairly overwhelming, that situation, being on a planet, you have no way of getting home. But if you just start by solving one problem and then solve the next and then solve the next, you now have a series of solutions that gets you closer to what it is that you're trying to achieve. Because obviously there'd be a high degree of uncertainty in getting yourself home from Mars. That in itself is overwhelming. It's too much. Where do you start? But sometimes you just need to default towards some action that is safe. We often say the reverse in medicine, sometimes don't, I'm forgetting the actual phrase we use, but sometimes just don't do anything, that.
Yeah, it's the don't just do something, stand there.
Stand there.
Sometimes, yeah.
Which is actually often probably quite useful, though in a crisis situation, when you do need action, then solving small problems sequentially does have compounding effects such that you didn't just solve one problem plus one problem equals 3 different solutions. You actually might have a net gain of 4 or 5.
Sure. Yeah, I think we're starting to brush into relationship between uncertainty and complex systems, right? Because there are nonlinear connections between a lot of this stuff. And so there's some tactical stuff that we do in there, right? I think in the trauma bay, and a lot of times in emergency situations or in a cardiac arrest situation or whatever, we want to bias towards action, right? Whether that action is move towards the patient, put your hand on their pulse, achieve IV access, like all of which you're basically doing to essentially shrink the problem set, right? There's all of this uncertainty, and without being able to diagnose a lot of it, sometimes these first moves are just allowing you dimensions of control or degrees of freedom to work the problem set, right? When our doctors go through our boards training, our oral boards training in the States, everybody is at speed in your head. What do you do in the first part of the case? IVO2 monitor, right? You put an IV in, you get oxygen ready, and you put them on a monitor. And it's this reflex. It's almost like a joke to say out loud. And sometimes you have to step back from folks and be like, why do you do that? Why is that your thing? The answer is it provides you degrees of freedom to work a problem. It takes you out of vapor lock into action, and it shrinks the problem because now you have the ability to apply other knowledge sets to it, similar to what you're saying, Andrew. And I want to go back to something that Eric said, and then we're going to reconnect this to complexity. So it's the sense of not being able to study your way out of a problem, right? So there was at some point, I don't know where this was from you all, but you do inherit this model, or you're taught this model that if you work hard enough and you learn enough, you will understand most of medicine, and that most of the time you'll be in a comfortable spot. Now, you won't always be in a comfortable spot, right? Because medicine has this concept of there's always something pushing the edge, or there's the next disease, or there's the next great discovery, or whatever it is. But that there was this fallacy almost that I inherited somehow that, yeah, if I just work really hard, most of the time it'll be okay. And then there'll be some weird stuff that happens on the outside. And in reality, that's not really how it works, right? A lot of the time you are practicing in an uncomfortable spot, in an uncertain spot where you're going based on best practices or instincts or like least bad options. But rarely are you like, yes, this is everybody understands this, we're doing this, and here's the idea to go behind it. I guess I'd invite you all, like, where did and sorry, let me connect the dots on this. Somewhere along the line in there, that model changed for me into one of being comfortable with operating in uncertainty. Never loving it necessarily, but being comfortable with it. So for you all, where did your relationship with that idea of knowledge versus certainty change? And then as the sister question to that, how do we bring people through the pipeline to be better versions of us in a way that helps them interact with uncertainty without putting them in this false trap that, like, if you study enough, you'll know the answer?
I don't think anybody wants to be a close version of me.
Fair, ditto. Yeah. But we like that is true. And also we are all physicians who are also teachers, right? We are all responsible for training in some ways, or part of the team responsible for training the next generation of physicians and nurses and advanced providers and everybody else that comes in our orbit. And there's this sense of, we were talking before we turned the mic on about storytelling, right? But there's this sense of what stories are we telling them about how the world works? And are those stories helping them or hurting them? And it's a weird thing to say, but uncertainty, complex systems, medicine, storytelling, these things are all like tightly related, right? In a way that like is actually much more real and much more present daily than I ever thought they would be when I was coming up through the ranks.
Yeah, so there's a lot to unpack there. So I think, I guess part of your question is like, at what point did I realize I can't study my way out of this? And I'll say, and I think I probably said this to both of you guys, and I've said it in a talk, I really got into this area of getting used to the uncertainty and trying to lean into being uncomfortable because my scope of practice is broad. Like there are some weeks where I'm chipping out rotten gallbladders, and some weeks I'm like plating ribs, sometimes in the ICU dealing with the end of life. And it's a lot of stuff. A lot of surgeons have the thing that they focus on, right? The cardiac surgeons are doing the Lima to the LAD, and there's the problem for me, and the curse of being an acute care surgeon is I'm a generalist, which means I don't do the same thing over and over again, or there wasn't a separation. And so I had this realization, like I can't do enough, see enough to really get good, to be like technically as proficient as some of my colleagues in other subspecialty. And now I've come to the point where I will say that to the trainees. Like, I'm not the slickest surgeon because I don't do 5 operations over and over again. It's always really different. But what I tried to hone in myself is, how do I get used to managing this kind of uncertainty and the judgment, the decision-making, everything like that. So that was, again, it's a personal thing for me, right? It wasn't like, oh yeah, I made it 10 years and I realized I still don't know everything. No, it was more like, how do I get really good? My skill set or my superpower isn't necessarily flashing. It's knowing when to or when not to. And I think that's how I approach it, if that makes sense.
Yeah, I think it happens, maybe Eric, and you're alluding to this. I don't think it happens in residency because you're so focused on acquiring content, acquiring knowledge, and moving yourself out of the Dunning-Kruger situation. And I think once you start to realize that, if you like look at the Pareto principle, that probably 80% of what we're learning or what we expect is only 20%. And then the reverse is 80% of the patients we see don't fit into the category that what's termed classic. In fact, I think I even tell our residents that it's like when somebody says it's a classic presentation, that means that they fall into the minority of patients, right? As I've learned along the way, probably within sometime after several years as being a staff, like 4 or 5 years, I started to realize that, to Eric's point, it's not about, certainly you want to try and gain some technical skills or certain knowledge-based skills, but where your expertise really comes from is being backstopped by some guiding principles in these situations, because you will never, or you will frequently encounter situations that are never precisely the same as the one before, because we don't work on an assembly line, right? So there are certainly predictable problems that we have, but they're never the same. And so if you try and rely on only a specific set of tools, you have to reframe your position in the department, in the emergency department, in medicine, whatever it might be, so that you're not there to solve the problem like at a granular level. It's okay, I'm going to take a step back and figure out how, knowing what I know and what I might be able to expect is going to happen in the future, I'm going to do a few things here that are going to get me closer to the answer or closer to a safer position for the patient or whatever it might be, or for the team. And so being a bit more guiding, I use a lot more guiding principles than I do necessarily like clear textbook type knowledge, though backstopped by ideally some evidence, maybe. I'm trying not to go rogue all the time.
Yeah, but
Sorry, Dan.
oh, yeah. What's interesting to me about this is that we have 3 people here who have taken different paths, and all of which landed, at least in part, on the idea that like technical skill and fund of knowledge is only a small part of what it is that we actually do. And where we provide differential value in some sense is on mapping theory into reality and looking at the mismatch and guiding folks through this fog of what's happening. And what's interesting to me about that is that if you look at the pipelines and the arcs of what it is to be in this position, multiple gates along the way, we're selecting people for the ability to absorb large amounts of knowledge. Like when you're going from college to medical school in the States, you're like, okay, did you pass this level of exams at a certain thing? Those level of exams aren't about uncertainty. They're about memorizing large amounts of facts and absorbing lots of knowledge. When you go from medical school to residency, like, sure, we're looking at how you perform clinically and we're looking at how did you do research, did you do other stuff, but a lot of the times we're also basing it on your scores on qualifying exams. And those qualifying exams are not about processing uncertainty. They're about absorbing fact. And so you could imagine two different circumstances here, one of which is that the ability to process uncertainty at the level we're describing is an emergent property of a system that only happens when you have enough fact baked into it. And it's literally just a bandwidth download problem, right? If you bandwidth enough and then you see enough cases, then you're likely to emerge into this concept of, hey, uncertainty is real and it's not going away and we need to work on it. Or you could imagine a different universe where sure, you need some facts in order to understand the system, but really you could or should start processing uncertainty way earlier in this arc. And that we're actually not selecting people for that. We're just the ones who happen to have that in addition to our ability to memorize a lot of things. So I don't really know what that is or what that should look like, but I'm not at all convinced that our current system is set up to bring people in who have whatever this common skill is that doesn't even really have a name that we do. We come from different paths, different training backgrounds, different arcs through this. And there's no uncertainty doctor, right? In the way that there's a traumatologist or an emergency doctor or an ICU doctor. So I don't know what to do with that, except that I genuinely wonder, like, where does this emerge from and how do we do it better?
Yeah, and I have a couple comments. One thing, it reminds me of, I think it's the Peter principle, is that what you're alluding to in terms of how we train people? We train them to be very good at memorizing content, or sorry, we select for those people to be very good at memorizing content, and we don't necessarily know whether they solve problems very well in uncertainty. In fact, many, you might argue, would probably hate that.
Yeah. Yeah.
Because they want certainty. And I think this comes from within you. People get promoted based on their current performance into a new role. It's like the employee that moves up into the director role where they were a great employee, but now they're a terrible director. I think that's the Peter principle. I think this like actually is, I hadn't thought the direction of the conversation might go this way, but this might be one of the most important ideas that we haven't yet grappled with very well in medicine in the age of AI. Because what we don't need now is we don't need those to guide us around knowledge and content, because that is at our fingertips. In fact, that comes so easily. What we need then is to have educators, leaders guide us around how to deal with that information and intertwining it into the real world. And that changes really how, us as educators will function and managing that uncertainty. And I'm not sure exactly how that looks, but I think it's really a piece that we no longer need to be spending time teaching learners content in the way that we used to do it. You could argue maybe even 10 years ago, 20 years ago, as Google became the answer to most things. But now I would say that's even 10x'd with the tools that we have now, with the models that exist. But what do you actually do with that? How do you integrate that? How do you interpret? How do you discard some of that information and integrate some others? That's where the synthesis and the analytics now become, that's where I would look to both of you, as that would be, if I was going to assign value to you, that's where your value really comes out in an age of AI where all of a sudden we've democratized to a level we've never seen before information, but we haven't fully democratized, and I don't know that we want to or should or how that would play out, democratize the analytics and management of uncertainty, because if there's uncertainty, then AI can't solve that necessarily.
I think it says, did I really need to spend so much time memorizing things in organic chemistry just so I go to medical school? But I think that's going to be an interesting step forward in terms of we will, and our trainees will have easy access to certain bits of data and bits of information. I think there's still an element of, in a time critical situation, you need to know things. Like there needs to be a basic fund of knowledge and things like that. But in some ways, it can be freeing because if you're not so hung up on memorizing certain things, then you move into this, you can then think about it in a lot better way. Two kind of quick thoughts or stories. A few years ago, there was a joint M&M in my last job, and there was a medicine and surgery thing, and there was a patient got transferred in, and it turned out a pretty kind of horrific outcome. Somebody from the medicine department was saying, well, I didn't feel comfortable doing this. And I, as the acute care surgeon, had taken the person to the operating room and done some stuff. And it was a heroic situation. And what I said at the meeting was, not feeling comfortable is so much of what I do. That's my job description, dealing with this uncertainty. And I got two different responses from that. There were a lot of people who were like, oh, I'm glad you said something like that. And then the boss was like, you never admit that. You're supposed to know what to do. Right? No, you're not always supposed to know what to do because the problems don't always have answers. With my trainees, I started to talk about this more. I gave a lecture about this a few months ago, and it was really, we have to acknowledge this uncertainty. We have to acknowledge that we don't always know. And it's interesting though, because what I'm finding is like some of the residents are very like, oh, that's cool. And some of them are terrified by that. There's one of them said, this is an existential crisis. I feel like I have to read enough because then it's going to get better. That's not what, there are lots of fields that aren't like that. And even if you think that you're in a relatively circumscribed section of medicine or whatever, the world is getting more complex. So the world is complex, and my definition of complexity wasn't mine, but the one that I use is, right, they're unforeseen interactions. Like we can't tell. And so any system that's really complex, we're not going to understand it fully. And as the complexity increases, we have to be, and our trainees have to be better equipped to deal with that. And the idea that somebody rolls in with, whether it's an injury pattern, what kind of medications are there and what's happening, the idea that we're going to somehow use AI to figure that problem out, there's going to be a partnership there because,
for sure,
again, there may not be an answer in a timely fashion for something that, for another system to figure out. And I think as humans, we live in that creative kind of dealing with uncertainty space. So, yeah, Andrew, I think it's great that you brought up AI, and I don't know where that's going to go. And somehow we all work with people who are running from that. And I think the goal is to figure out how do we incorporate that into our teaching? How to make things better? But yeah, I haven't figured out how to teach. It's taken me years to teach myself this, right? So I'm not sure how to teach the trainees how to get used to being uncomfortable. And quite honestly, there's some folks in the corner office who said, why would you talk about that? And I try to talk about those cases where I didn't know, or the mistakes that I've made, because that's part of the training process and that's part of the reality. But I think, so I don't have an answer, but that's how I'm dealing with it, to just talk about it, acknowledge it.
Yeah, I think, and then I think like also talking about what are the tactics that you use in those situations, incredibly valuable. One, calling it out that you as an experienced surgeon don't have the answers in the moment, but you do have a set of first steps that you would, and what would you do? How would you approach that? What are the things that go through your mind that help you make that decision? Whether it be some degree of, one thing that I like to do is assign probabilities to a thing, like explicit probabilities to what I think I might be seeing in front of me. So that I then can be more objective with how I should proceed. And for example, if I see a patient with right lower quadrant pain, I could say that's most likely appendicitis. Sure. I think we as humans, like in our minds, when we hear most likely, we assume we translate that into it is appendicitis. That's not actually true. There's a few, we can construct a differential diagnosis for that. Rather, it's probably more useful for me to say, I think it's about a 90% chance that's appendicitis. inherent in that statement is that it's a 10% chance it's something else. That then allows me to be a little bit more strategic in, do I need further diagnostics? How do I proceed with that? And I'm open to the fact that I might be wrong with my leading diagnosis.
Yeah, I think that's interesting. I don't view it in exactly the same way, Andrew, because I don't think about it in percentages, but I think what you just said, the latter part of what you said there, though, is the critical part of that, at least for me. If you say that something is 90% likely, you have to acknowledge that 10%, the 10% is important. Consider the alternative. How might I be wrong? And I think that's, again, what I have learned and what I try to speak about is, what could it not be? Like, what am I missing? So I don't have within the time, or my brain doesn't work in a way to say, okay, this is 80% versus 50%. Usually, right, 20, 50, 80, and we think 90 is almost 100. But I think I try to stress, like, what could it not be? And for all of us clinically, a lot of it's, what is it that we're missing that could kill the patient? And then you move beyond that. If you've gotten through that hierarchy, then you have more time to think about what the rest of the differential is. But I think considering the alternative, and then the other part about what you said there, Andrew, that I love is, I could be wrong. And I think that's the other part that I try to stress with myself and I try to stress with the trainees, is that you have to be cognizant that you're going to make a decision to keep moving forward, but you might be wrong. That's okay, but you have to be vigilant, right? There's going to be some metric. You have to be really vigilant. And then you have to be humble enough to be like, oh shit, I was wrong. Now what do I do? I think packed into what you're saying, Andrew, about using percentages is actually a lot of stuff, right? Because, and not just, oh yeah, I think this is a 90% chance I'm right. There's 10% chance I could be wrong. And how do I, as you said, what other things do I need to do to make sure it's not that 10 or 20%? And so that's the sort of stuff that I try to lean into a little bit.
Yeah, I wonder too, if it's even, are you wrong? If you say it's 90% chance it's appendicitis, or that you are saying it's a 10% chance, you're just giving a leading indicator as to where you think this is going to go. And obviously I'm wrong. My wife would disagree that I ever admit that, but I'm wrong more than I'm right, I think. But this idea that you have an alternative is really something that we don't do, I think, as good of a job teaching. Comes in a little bit as we teach people how differential diagnoses. That part of medicine is done very well. But within life and within high-level decision-making within a resuscitation, within how you manage interpersonal decisions, all of that, we don't often consider alternatives explicitly because we fail to think, whether you assign an actual probability or not, and how Bayesian you think, but I think it really is important that gets integrated into that decision-making, because to Dan's original comments around uncertainty, that's exactly what we're dealing with here. We don't have certainty, so we just have a spectrum of probabilities.
Yeah, just to zoom out for 1 second. So the philosopher John Kabat-Zinn said, I can't control the waves, but I can learn to surf. And I think that's ultimately what we're talking about here, right? Like that question I asked at the beginning of how much can you reduce uncertainty? My answer to that is there is irreducible uncertainty in what we do.
Of course.
Right? There's irreducible uncertainty. And there's part of our job is to understand that not all uncertainty will go away, become comfortable with that, to learn that. And then part of our job is to learn how to surf that, right? To really say, okay, if there is irreducible uncertainty, how do we best interface with the universe? You can't go to the ocean and be like, I wish there wasn't a wave there. The wave's going to just destroy you, right? Like, you instead have to be like, okay, this wave will do some things, some of which I can break and some of which I can't. So now let me learn how to operate in a universe where waves exist. I am small, the wave is big. And what do I do about that reality? Right? So you're tuning yourself to the reality and trying to do it. And what we're talking about here, when we're talking about it's an existential crisis to go from a vision of the universe where you can know everything to a vision of the universe where there is irreducible complexity, right? That's acknowledging that waves exist and you're small. And then this other stuff we're talking about, should we use percentages to label it? Should we over-index on counterfactuals? How do we understand when we're changing paths, when we're wrong? How do we communicate to the team what's acceptable and what isn't? This is the language of learning to surf, right? This is saying, we agree there's irreducible uncertainty. Now, what do we do about it? And in my mind, you actually have to do both of those tasks, right? You have to admit you can't control the wave, and you have to learn how to surf. And our job as instructors, as teachers, as guides is to help people go through that existential crisis. Which probably means we need to stop totally selecting on people that love certainty, right? And then also help them learn how to surf. Hey, I just got hit by this wave. Here's what I did differently, blah, 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 blah. And I don't know. I think that's both our job. And we can take that anywhere we want, right? Like we can go more technically deep into how do you do it. We can go more existential into what do you do with the first part. But I don't know, in my mind, they're both of pretty equal importance in there.
Dan, you talked about learning. One of the things that I was never taught was this idea of, I was taught how to debrief because I run a lot of simulations. So we debrief a scenario, but it was not taught to me or emphasize the importance of debriefing decisions. What was I actually thinking in that moment? Why I went with one path and not another? Did I have an alternative? I would debrief. I was taught how to debrief. Did you make a timely decision to intubate the patient? Fine. But
Sure.
But what were a little bit more in depth on, were you tired when you were making those decisions? What else was distracting you? Did you consider any alternatives? This idea that you are deliberate, because with anything we learn, the key part of learning is the reflective process, right? And so decision making is a skill like anything else. This isn't inherent. It's just that we do it so frequently that we think like breathing. It isn't part of the autonomic nervous system to make decisions, but it does start at an early age. At least I don't think it's part of the autonomic nervous system. But you know what I'm getting at? This idea that it isn't so innate. It's experienced so early that I think we treat it like breathing. But in fact, you can get better at it. In fact, you can get better at breathing too. You can actually train your body to improve your breathing under certain circumstances. So I think everything can be improved upon, particularly decision making.
So it's part of the path that I went down because I decided I wanted to get better at my clinical decision making, which led me down the Kahneman pathway and Gary Klein and Kurt Gigerenzer. And then part of that was I'm dealing with patients and situations that are falling apart. So let me learn how to manage failure, so I'm not going to be in those situations. So let me read about Challenger and Fukushima and it was like this library of catastrophe, because that was going to get me figure out how to take care of my patients better. It has, but not in the way that I expected, because you can't avoid, again, in a complex system, you can't avoid some degree of failure. And so, again, my pathway to this has been different. Yeah. But I do think that I've tried to get comfortable being uncomfortable. To your point, Dan, like, you can't fight the waves, right? You're gonna deal with that as you do.
Eric, are you on your path to getting uncomfortable, being comfortable, being uncomfortable, and the reflection on decision making? Do you debrief decisions? Do you I'm curious, like, what do you do? Because I've started.
So you guys have been through the training. You've been to surgery, morbidity, mortality conferences. And so once a week, we sit in an auditorium and somebody presents a case that went sideways or didn't go well. And people in the audience, they throw rocks and tomatoes at the person who's up on stage. And what I have started doing in the last few years, the psychological safety is a lip service. But part of what I've started to do, more so with the trainees, is that, as you say, like, what were you thinking at the time, right? Oh, we did this. Why did you do that? What were the circumstances? What's the context? And this is, again, me mentally, when I break this down between at 2 a.m, and you've got 5 patients, and does this person need to go to the operator? I'm not sure. They're not that bad. The helicopter's on the way. And you're slugging down cold coffee because it's fuel, whatever. And then when you're sitting in the auditorium on a Wednesday morning and you've got people got a full night's sleep and they've got their nice coffee in a mug and they're steaming and there's no vomit on the shoes and stuff like that, people say, why didn't you do that? The context really matters. And so I have tried to pull it back to what were you thinking at the time to try to escape from the kind of the hindsight bias and the outcome bias that is there, because hindsight bias kills learning. That as soon as people are saying, oh, you should have done that, they should have done that, you weren't there. So let's ask the question of what were you thinking at the time to make the decision? And so I try to do that myself. I try to do that. The trainees are more receptive, I think, because surgeons are surgeons. And so there are plenty of people who are like, I know the answer and that's that. Right. But I try to tease it out. What were you thinking? Or conversely, I'll say, this is what I was thinking. And this is why I did this. I don't know if you guys have read the book Being Wrong by Catherine Schultz, but it's this great kind of exploration of what wrongness is like. But one of her points that I love is, what does being wrong feel like? It feels like being right. And so her point is being wrong happens after the fact. Like none of us set out to cut the common bile duct, right? But those things happen. And so we have to acknowledge that at the moment, we didn't have perfect information. We didn't have perfect information. There's a time pressure. There's all that uncertainty, whatever box you want to say. After the fact, we know the answer. So at 2 a.m, we don't know the answer. A week later, Wednesday afternoon, we know the answer. And then it's very easy to say, you did the wrong thing. Maybe you did, or maybe I did, but there's a reason. And then if the outcome is not what I wanted it to be, what's my contribution to that? And how do I learn from that? And the other thing that I'll say real quickly that I'll show is the problem with learning in that environment is that you have an N of 1 or N like small numbers, and you really run the risk of learning the wrong lessons from a single case. So to your point, Andrew, what I really try to drill down on is what's the decision? Not, I decided to do this. Was it the right decision? But the person died anyway. Like that's something you have to separate the outcome from the process. And
For sure.
I've been trying to teach that. It's really hard to do. It's really hard to do for myself. It's hard to do for trainees and everything. But yeah, and it takes time. Like that reflection takes time. I try to write things down to keep track of it, but it takes time and effort, which is why then having done all that, I feel the need now to get out and talk to other people about it, because hopefully it's time well spent.
Guys, this is amazing. We're just barely scratching the surface on this, but unfortunately I have to spin us down for this conversation. So what I want to do as we're ending here is give you all a chance to issue a challenge to folks that are listening to this, right? Anything you want them to do differently or better after listening to this podcast. And while you guys are thinking about that for a second, to buy you a moment of time, I'm going to give our normal disclaimer, which is that all of us here are on this podcast representing only ourselves, right? We don't speak for the companies or groups that we work with. We certainly don't provide medical advice, and we're just out here trying to make the world a better place as we're doing this. So with that disclaimer in hand, who wants to go first? What are we going to challenge folks with?
Okay. I would say for people who have trainees, for people who teach, I would challenge people to talk about a situation where they themselves were uncertain, uncomfortable, failed, to acknowledge everything that we're talking about, to bring it to light, to say that there isn't always an answer.
Love it.
I love that, actually. I think even if you don't have trainees, if you're in any position of leadership where people, or even if you're within a flat hierarchy within a team, but sharing those ideas or those instances, I think is incredibly important. I guess I would challenge people to make a deliberate effort to debrief their own decisions and seek out and give people an opportunity to give them input on those decisions. So create an environment where that's suitable to say, listen, Dan, I'm going to run this trauma resuscitation. I wouldn't mind for you to give me some feedback on that. And we're going to focus less on the outcome, like to Eric's point, and more about the process. And in fact, it shouldn't just be those situations where there's morbidity or mortality that occurs. But far more likely is that we are going to have some degree of success because we're working with a high performing team. So I would say that we should be doing a debrief, pick in sometime in the next year, debrief one particular instance, big decision, high stakes decision that went well, and aligned with the stated outcome, and pick one that didn't, but the outcome matters less than the actual process. And that would be the challenge to the listeners, or to me even, over the next, and to you over the next year.
Love it. Eric, Andrew, thank you all so much for coming on the podcast. I know we turned over a lot of rocks and just barely scratched the surface of what's underneath it. I think that there's a ton of stuff in here, and I certainly hope this is the start of a series of conversations, not the end of it.
Thanks, Dan, for having us. It's great.
Yeah, thanks, Dan. It's always fun to kind of exchange ideas, and I don't know, to me, it's always Brown in motion, which I love. So I'd love to do it again.
And I just want to give a big shout out to you, Dan, and all the work that you've been doing with the podcast, and Mission Critical Institute has been amazing to follow and watch, and I've continued to learn. So thank you for putting out that content.
Right on.